So my task today is to walk you through what the best treatment pathway is for nodular lymphocyte predominant Hodgkin lymphoma. And before I dive into the details, I'd really like to thank Smriti and the rest of the organizers for giving me this opportunity to speak. These are my disclosures. So nodular lymphocyte predominant Hodgkin's is a distinct clinical entity. There's male predominance. It's about 65 to 85% of the cases. It's seen in pediatric and adults with a median age of approximately 35 years. Most patients, 70 to 80%, are asymptomatic and have early stage 1 or 2 disease. It involves mainly the peripheral nodes, and the mediastinum is usually spared. It's often non-bulky. A bone marrow biopsy is indicated only if there are B symptoms or cytopenias. It behaves indolently with late relapses, even 15, 20 years later. And you can see histologic transformation to diffuse large B-cell lymphoma, most commonly to the T-cell rich subtype. And the incidence of that is anywhere about 7% at 10 years, ranging from 2 to 18% depending on the series. And immunoarchitectural patterns from A to D have been described. Pathologically and genetically, this is different from classic Hodgkin lymphoma. So if you just look at the immunohistochemistry markers, nodular lymphocyte predominant Hodgkin's does not express CD30, CD15, and unlike classic Hodgkin lymphoma, which are almost always positive. Very rarely you can see it, but if you really think of the most common scenarios, there's no CD30, no CD15. And in contrast, there's very strong B-cell marker expression. So you get sheets of CD20 positive cells with bright with PAX5 staining, unlike classic Hodgkin lymphoma, where those are rare. Even at a genetic level, the biology is completely different from both those entities. Now, nodular lymphocyte predominant Hodgkin, and I mentioned it can transform into a T histiocyte rich like large cell lymphoma. And if you look at the genomic level, there are actually similarities between those two entities. So if you look like nodular lymphocyte predominant, there are some common genomic features between those two, and it's quite different from what you get in classic Hodgkin lymphoma. So there are 6 immunoarchitectural patterns described. A and B are considered normal variants, whereas C, D, E, and F are the variant patterns. And the higher the number, the more aggressive it is. And in fact, the E and F are almost considered like a DLBCL. So the Germans developed a score with a male, low albumin, and one of the variant patterns. And a variant pattern being defined as non-A, non-B, so anywhere D, E, or F. And that predicted for progression-free survival. So what we don't know is whether it correlated with the likelihood of transformation. So if you look at the impact of the variant patterns in nodular lymphocyte predominant, if you see bone marrow involvement, which is very, very rare in this entity, less than 10%, whenever you see it, it's usually associated with a variant pattern. Even in stage 1 or 2 disease, the ILROG pattern, the ILROG study, when they looked at the inferior progression-free survival, if there were a variant pattern or more than 2 sites of disease. And of course, for advanced stage disease, those patients present with more stage 4 disease and splenic involvement. So they really don't present like their clinical presentation is also more aggressive, and it has implications for treatment. So it's important to ask your pathologist to report the variant pattern. So if you look at just the age-specific rates and the subtype by overall survival, if you look at lymphocyte predominant, you can see that there's no bimodal peak like you have in classic Hodgkin lymphoma. And if you look at the relative overall survival, it's almost 90 to 100%, unlike the other histologies in lymphoma. Now, one thing to remember clinically that you can see this pattern of continuous relapse. So in classic Hodgkin lymphoma, once you cross 5 years, we usually tell the patients you're cured. And the chances of the disease coming back are probably less than 2%. That's not the case in nodular LP, where you can see, even look at the British Columbia data, where you look at the matched pair outcome analysis, you can get late relapses. It doesn't impact survival, though, because outcomes are very good in this disease. And this is the German data where, compared to classic Hodgkin lymphoma, you again don't see any flat line, and you can see late relapses. This is up to 12 years, but you can see relapses even 20, 25 years later. So therapy choices vary from radiotherapy to chemotherapy to then rituximab-based therapy. And it's interesting that the therapy choices actually are different from classic Hodgkin lymphoma. And you approach nodular LP more like a follicular lymphoma. So if you look at the choices in follicular lymphoma and the NCCN guidelines, you have, like, if you have early stage, radiotherapy is preferred. If you have advanced stage and there's no indication for treatment, it's observation. That's pretty much the case even for nodular LP, where if you have stage 1 or 2 disease, if it's non-bulky, radiotherapy is the preferred option. And if you have stage 3 or 4 disease, if you're asymptomatic, observation is also indicated. So there are paradigms which are different. So often we see practitioners making the mistake because they see the word Hodgkin's, and a lot of patients land up getting therapy which is not really warranted. Even at relapse, the therapy differs from classic Hodgkin because it can include observation, it can include radiotherapy, it can even include rituximab because of the universal CD20 expression. And relapse Hodgkin's, you would give salvage and transplant, and that's not necessarily the case for nodular LP. So now going back to stage 1 disease, the choice, where this is a big study with mature follow-up, which showed that within radiotherapy, involved field radiotherapy was really with very, very good outcomes, much equivalent to the extended field or combined modality. And you really don't need combined modality because involved field radiotherapy does very well. Now, there's a big temptation to use Rituxan alone because these express CD20. That has been studied. And the only wrong choice in early stage disease is to do Rituxan alone, especially if radiotherapy can be given, because the outcomes, if you look at the progression-free survival, it's only 80% compared to a much higher progression-free survival with involved field radiotherapy of over 90%. This is the ILROG data. So if you compare within early stage 1 and stage 2, well, stage 1 and 2 does very well with radiotherapy. But if you look within stage 1 and 2, if people have more than 2 sites of disease, they tend to do better with combined modality therapy than radiotherapy alone. And then the risk factors for not doing well are this variant pattern I talked to you about. And of course, if you have more than 2 sites of disease to make it stage 2. We also have looked at the patterns of relapse or transformation rate progression. And so if you look at radiotherapy containing regimens, there's almost very rare to get a relapse. And if you get it, it's mainly a distant relapse. It's very rare to get local relapse. In contrast, if you don't use radiotherapy and you just use chemotherapy, you do see local relapses and then you do see some distant relapses as well. But there's no really outcome overall survival difference between transformation or no transformation. And for early stage, the risk of transformation is pretty low. It's only about 3.8% at about 10 years. And the risk depends on variant histology and if you have more than 2 sites of disease. What about the radiotherapy field? So remember, nobody uses extended field anymore. It went down to involved field radiotherapy with very good results. And now it's ISRT, which was involved site radiotherapy. And this is data from the MD Anderson group, which shows that even with involved site radiotherapy, the 5-year progression-free survival in its retrospective analysis was 100%, with an overall survival of also 100%, with no difference between the modalities. Now, if you have people with stage 1 disease where the lymph node has been completely resected to make the diagnosis or whatever, observation is a very reasonable choice. And that is extrapolated from the pediatric literature. And you can see that they observed patients post-resection if it was just a single site, and the event-free survival was 77%. But if the patient relapsed post-surgery or hadn't had all the sites resected, they got chemotherapy with idrimycin, vincristine, prednisone, and cytoxan for 3 cycles. And you can see that the event-free survival was, again, 88%. But with this approach, 75% are spared chemotherapy and radiotherapy. And for the ones who are in the pediatric literature, those who are treated with radiotherapy, with this chemotherapy, they can avoid radiotherapy. Active surveillance is also a reasonable option even without resection. This is data from Memorial, which looked at 163 patients, out of which about 2/3 were early stage patients. And you can see that there was no difference in progression-free survival or overall survival. This p-value here is actually in favor of observation. There was absolutely no increased risk of transformation, and patients could be treated very easily when they eventually relapsed. So like a low-grade lymphoma, if you have low-volume disease, which is advanced stage or even early stage, which has been resected, surveillance is an option. Now, if you look at advanced stage disease and compare the outcomes with classic Hodgkin lymphoma, with median follow-up 11 years with ABVD-like regimen, you can see that the progression-free survival is in the 60% range, unlike the 80-90% range you see with classic Hodgkin lymphoma. And this is because of the late relapses. So, where ABVD, which has very weak alkylator like DTIC, is very good for Hodgkin's, there's emerging data suggesting that for nodular lymphocyte predominant Hodgkin, you need a better alkylator like Cytoxan. So maybe a R-CHOP or RCVP approach is a better approach. There are no randomized trials to suggest that, but cumulatively the data from a lot of retrospective series suggests that. And the risk risk factors for poor outcomes if you have splenic involvement, bulky disease more than 5 centimeters. So R-CHOP has been tried. This is data from MD Anderson with about 59 patients. About 27 of them had R-CHOP. Half of them had stage 3 or 4 disease, and at a median follow-up of about 7 years, the progression-free survival is 88%, and at 10 years, it goes down to 60%. So even with R-CHOP, you can even get these late relapses. But it's a reasonable choice if you have advanced stage disease or bulky disease. The German Hodgkin study group in their HT18 study included nodular LP with classic Hodgkin. And this gives an opportunity to look at the differences of the clinical features. So as you can see, there's much more stage 4 disease with classic Hodgkin lymphoma. There is very little B symptoms in nodular lymphocyte predominant disease. It almost never has a large mediastinal mass, and it almost never has an elevated ESR. So if you have any of those things, you really need to make sure that you've talked to your pathologist again. And also variant histologies are seen in about half the patients, 60% of the patients with advanced stage disease, where it's much less in patients with early stage disease. So in advanced stage, remember in the German Hodgkin study group, they use Biacop, which is a very alkylator-heavy based therapy. So that's why there were no differences in outcome between nodular LP and classic Hodgkin, because you're giving them a very heavy alkylator-based therapy. And in the interim PET2 negative, whether you did 4 cycles of escalated Biacop or you did 8 cycles or added Rituxan, it really didn't make a difference. And again, the PET2 positive, the nodular LP, did worse than classic Hodgkin lymphoma, and about 60% had the variant histology. Again, there's no impact on overall survival. These patients tend to do very well, even if they have transformed. Now, how do you treat relapse disease? Again, as I said, like a low-grade lymphoma, this can transform to a more aggressive lymphoma. And that's why biopsying it is really important to make sure that you're not missing a transformation. And that can happen in stage 1 or 2, where the risk is really low, about 3.8%. And then in more advanced disease, the risk can go as much to about 14 to 15%, depending on the series. And what we've seen is that if you have stage 3 or 4 disease, or if you have splenic involvement, that is a particular risk factor for transformation. So if you have a patient with stage 3 disease with splenic involvement, you're not going to take a spleen out to prove the point, but I think you can assume that that patient has transformation and not do ABVD. You can treat that patient with R-CHOP. Rituxan has been used as a single agent in relapsed nodular LP because of the universal CD20 expression. And we looked at our data and median follow-up of almost 8 or 9 years. And you can see that the progression-free survival, there's no plateau. But the overall survival is excellent. It's over 90%. So again, it's a very useful drug, but as a single agent, the responses are not very durable. Lots of series have looked at outcomes post-transplant, but you have to be careful when you interpret that data because many of them included patients who had variant histology or we just didn't know at that time. So if you just look at or they included patients with transformation. But if you just look at a series from the EBMT with 60 patients, which actually excluded patients with transformation and had chemosensitive disease, the 5-year overall progression-free survival is 66%, overall survival 87%. again, quite similar to what you see in relapsed aggressive lymphoma. And in the German study, they compared giving single agent Rituxan or radiotherapy alone with giving our chemotherapy or transplant at relapse disease. And you can see that all the outcomes were all very similar. So if you're using aggressive, so not all patients require high dose therapy and transplant. It all depends on what the prior therapy has been. And the overall survival, according to the time of nodular LP recurrence, is important. So if they relapse after 1 year, their outcomes are actually very good. But if they relapse within the first year, which are mainly the patients who have variant histology or have transformed, then the outcomes are not as robust. This is the North American data, where again, if you exclude patients with transformation at first relapse, you can see that transformation beyond the first relapse at 17% at a median at 3 years. There's no difference if you have progression of disease within 2 years or after 2 years. So what is the best treatment pathway? So for early stage, there is excellent outcomes with limited field radiotherapy alone for stage 1A, and that is the therapy of choice, ISRT, the 30 gray. Radiotherapy alone may also be appropriated for selected patients with contiguous stage 2 without risk factors. Combined modality, ABVD-based, warrants consideration. If you have unfavorable features such as variant patterns or stage 2 disease with 2 sites of involvement, and there are no large series with chemotherapy alone. There's no role for Rituxan monotherapy. It's reasonable to consider adding Rituxan to ABVD for early stage, and observation is acceptable for patients with stage 1 who are NED after excision. What about advanced stage? It's really important to have very careful pathology review to rule out large cell transformation. And for the choice of therapy, you can't be dogmatic. So you can use ABVD based on the British Columbia data. So in North America, many centers do that. In Europe, escalated BRCOP is used, and it's very reasonable to consider adding Rituxan. And there's some data to suggest that treating with an alkylator like regimen like R-CHOP may have better outcomes. So what I do is I use R-CHOP if I suspect that there's transformation or suspicious pathology. So if you have splenic disease or stage 3 disease, abdominal involvement, or if there are variant patterns, D, E, and F. For relapse disease, again, rebiopsy is really important to rule out large cell transformation. And in your choice of site of biopsy, it's important you biopsy the bulky site or an intra-abdominal node, sometimes a splenectomy, and not just a simple, easy to access node, because that may give you a discordant histology. For an isolated relapse, radiotherapy alone, if there's no prior radiotherapy, and you can observe it has been completely excised. And if there's a systemic relapse, you can do Rituxan alone if there's not bulky disease. You can do salvage and transplant like you do for large cell transformation, or if you have very symptomatic bulky disease, and again, like a low-grade lymphoma, you can do observation if there's low tumor burden. So that is my last slide, and I am happy to take questions. I will stop sharing my screen.
Thank you, ma'am, for the excellent discussion. We have a few questions. The first question that I've seen in the chat box is, would we use a regimen that is rituximab, that is R-ABVD, or is it better to use R-CHOP? And if we use R-ABVD, how do we dose the R, and how do we sequence and dose rituximab?
I think I spelt it out in the talk. For early stage 1 and 2, if you have stage 2 disease and it's non-contiguous, so you're not going to use radiotherapy alone, and you're going to use combined modality therapy, it's okay to use R-ABVD if there's no variant histology. And the R dose is standard, 375 per meter squared, and you give it on the same day as ABVD. And you do ABVD every 2 weeks like you would normally do. If you have stage 3 or 4 disease, we prefer to use R-CHOP.
Okay, ma'am. Thank you. Ma'am, in advanced stage disease, any particular subset in which we should be considering to use the intensified BCOP regimen rather than R-CHOP? Any particular subset practically in our clinical practice?
No. I think you can use R-CHOP for stage 3 or 4 disease.
Okay, ma'am. Ma'am, and in the relapse subset, a few of the patients, even if they relapse, like you have told in your talk, they still have good outcomes even with the standard regimens. So there are few patients that can go on receiving these multiple lines of chemotherapy or maybe some radiation. But the one subset of patients, which one of those should directly go for the high dose chemotherapy and transplant? Like which subset of patients we should consider?
Well, the subset is if you have somebody who has presented at diagnosis with stage 3 or 4 disease, and you've given them R-CHOP, because they have variant histology, and then they relapse. You have to think of that as relapsed DLBCL, and that's the group I would give salvage and take them to transplant. If, however, somebody with stage 1 or 2 disease who relapses, 8-10 years later, you can watch them. You can do Rituxan alone. So it depends on the clinical presentation.
Yes, ma'am. Thank you, ma'am. One more question in the chat box. In relapse and refractory cases, is there any role for immunotherapy?
I think you mean the checkpoint inhibitors.
Yes, ma'am. Checkpoint inhibitors. Yes.
I mean, Rituxan is immunotherapy too. So no, in nodular LP, there is no role for the checkpoint inhibitors. Unlike classic Hodgkin lymphoma, where they're very active, in nodular LP, they have no activity.
Okay, ma'am. Okay. So
in DLBCL, they have no activity.
Yes, ma'am. And any role of ofatumab besides rituximab? Any data for that?
Well, there is data from the German Hodgkin study group, but it's no better than using rituximab. So yes, there is data for lots of CD20, any of the CD20 antibodies. There's data, even there are case reports with radioimmunotherapy also. So all of those are active, but I would say that the activity is pretty comparable with rituximab. And since all of us know how to use rituximab pretty well, I don't think there's any deviation required from that.
Okay, ma'am. And one of the last questions is for those patients who go for high dose chemotherapy followed by transplant, any particular choice between RIs, R-DHAP, R-SHAP, any particular choice?
Use a regimen which you're familiar with.
Okay.
Any of them, they're all equivalent. And when you have these multiple choices, it's best to use get good at using one regimen. Okay. So gets expertise, the more you do the same thing. And so that's what we teach our fellows also, like you pick whatever you want. They're all pretty equivalent, but get good at doing that again and again and again. I don't think there's advantage of one over the other. They're all platinum based. It depends on the comorbidities of a patient. And if the patient has, renal thing, you're not going to give cisplatin. You're not going to use RDHAP. If the patient has a lot of neuropathy, you're not going to do that. So I think you have to individualize it a bit, but they're all pretty equivalent.
Yes, ma'am. Thank you so much for the excellent discussion. Thank you for answering all our practical queries also.
Sure.
Thank you, Dr. Ranjana Advani. I know you squeezed in your lecture and I'm really grateful for that. And we look forward to more interactions with you in future, especially in lymphoma series.
Sure.
Thank you.
Thank you. Thanks all. Bye.